Anna, and I will be moderating this session today. A few house rules. Please turn your cameras and mics off and try and avoid doodling on the screen as it disrupts the recording for other people. Apart from that, just sit back and enjoy the session. We have two speakers. Our first speaker is Mr. Anthony Kinnear, who is going on to be an ST5 on the Royal London rotation. He's a great registrar and even a better teacher, and he'll be going through hip fractures. And then we have Mr. Alazzawi, who is a trauma and orthopedic consultant at St. George's Hospital. He specializes in hips and knees. And he's also a publication machine with over 30 publications, as well as being a reviewer for bone and joint, as well as injury. So we're going to start with Mr. Kinnear. You might need to unmute yourself.
Okay, yeah. And then share screen. Okay, thanks for inviting me to talk here, Kinnear, today. Like I said, my name is Anthony Kinnear. I'm one of the ST4s currently on the Royal London rotation. And today we're going to be covering the rather large topic of hip fractures. We're going to hopefully cover all of fragility hip fractures. And then if we have time, we're going to touch on young adult hip fractures at the end. So these are the objectives, like I mentioned, go through fragility hip fractures, looking at the evidence and guidelines behind them, classification, and how we treat these. And if we get time at the end to go on to adult hip fractures. So I realized that there's probably going to be a range of you in this lecture. Some of you are F1s right up to CT2s. Therefore, you're all going to have different experience levels. Anyone who's done an orthopedic rotation for even just a couple of months will undoubtedly be familiar with large parts of this talk. But I do hope to highlight exactly what you should know for your interviews and what you should know as a day one registrar. So to start with, fragility hip fractures. Why are they such a big deal? Well, there's over 70,000 that occur annually in the UK, and the total cost of care is over 2 billion a year. We can see that they have a very high mortality rate. In fact, the diagnosis was considered to be an end-of-life diagnosis prior to the treatments that we have today. It was considered as a failure of your biology. Your bones should not break from a standing height. And if they do, it means that you're more likely to have a lot of other stuff going on as well. So the neck of femur population tend to be quite tricky customers. Because of this, the British Orthopaedic Association have produced BOAST Guidance on how to manage hip fractures. This you certainly will need to know for your interview, and you could certainly be expected to talk about the 12 standards of audit. The thing that we all take away from this as orthopedic surgeons, the most obvious point, is that we need to perform an operation so that these guys can fully weight bear in the immediate post-operative period. It's important to note this has been so successful that the BOA have now rolled out the guidelines to other parts of the body where we can preserve function or allow weight bearing in this elderly population. One thing you'll also come across in the BOAST guidance is timing of surgery. There have been multiple studies over the last 15 to 20 years. I've just highlighted two meta-analyses, one from 2018 and one from 2010. They all pretty much say the same thing. They sometimes vary on the time between 24 to 48 hours. But the key message is that early surgery decreases mortality and decreases complications. You will also need to be aware of the best practice tariff. This is an additional payment that the hospital receives for meeting the following criteria that I've put on this slide. When I last checked, it was £445. It is important to note that the money is only paid if all of the criteria are achieved. And that really just shows how multidisciplinary the approach to treating the fragility hip fractures is. So how do we go from admission to surgery. Well, much of this you guys would be familiar with. I'm guessing the vast majority of you are SHOs, so we're not going to go through this in detail, but I did want to highlight the examination. It's always important to document a neurovascular status as well. But often, sometimes we're referred these patients and we've looked at the x-rays, and so we kind of know the diagnosis before we see them, or we go to see them and they've clearly got a shortened and externally rotated leg. You shouldn't be causing pain to these patients, so you don't need to start jacking their legs around. However, what do you do if the diagnosis is uncertain? Well, first of all, you want to know if the patient can weight bear. And then if they can't, you want to know if they can straight leg raise. If they can't, what do you then do? So the first thing to mention is most people perform a log roll where they gently internally or externally rotate the leg, and that can usually give the diagnosis. If it's still uncertain, one of the things I do both in most of my examinations, especially in trauma calls, is just apply gentle axial traction, which can often help localize the pain. It can also help distinguish from pubic rami fractures. If your diagnosis is still ambiguous despite your AP and lateral pelvic x-rays, then the gold standard is to perform an MRI scan. However, the guidelines do clearly state that if there is going to be an unacceptable delay in obtaining an MRI, then a CT is more than adequate. The last point on the slide is to optimize. We want to get these guys to theatre in the best condition possible. However, I'm going to show you this paper from the Association of Anaesthetists that was released in 2020, which highlights the 7 acceptable reasons that they consider for delaying surgery for hip fractures. So this is actually something that I keep bookmarked on my iPhone when I go to team briefs. So we're going to start with how we classify our neck of femur fractures. And I'm sure we're going to revisit some anatomy, and I'm sure you're all quite familiar with it, but we're just going to go over the bony anatomy first. So we have a simple diagram here with 1 pointing to the acetabular rim, 2 points to the ischial tuberosity, which is what we sit on, 3 points to the iliac crest, and then 4, 5, and 6 point to the femoral head, the femoral neck, and the greater trochanter, with 7 demonstrating the shaft. This is just another slide, just confirming what we talked about and showing a bit more of the anatomy in a bit more detail. So we've started with the bony anatomy because that's often the first thing that we can see when we're looking at radiographs. And so what I just want to go into briefly now are the radiographic markers that can help us in both identifying a fracture, but also as a reduction tool when we are fixing these fractures. The first of which I'm sure that most of you have heard of is called Shenton's line. And this is a smooth line, as you can see by the yellow dot, that runs along the inferior border of the superior pubic ramus to the inferior medial border of the neck of the femur. And it should be a smooth line. If there's a disruption in this line, we do need to consider whether there's been a fracture. But also, again, I mentioned that it can be useful when we're trying to reduce these fractures in theatre. The second radiological markers I'm going to talk about are trabecular patterns. What are trabecular? Well, so these guys are bands or struts or rods that basically help support the femur. There are primary and secondary patterns that can be formed due to compressive and tensile forces. That is according to Wolff's law, which in its simplest form basically states that bone remodels these bands according to the stresses that it undergoes. You can see the triangle there and the W. That is considered the weak point of the neck of the femur. And also that triangle, again, can be helpful when we're trying to reduce these fractures in theatre. So now we're going to move on to the soft tissue anatomy. Firstly, the labrum acts like a suction seal, keeping that head within the joint. It increases stability and it also increases the surface area, therefore reducing the joint stress across. The other thing to mention is the capsule. Now, this is really important. The capsule, the joint capsule for the hip is quite different from the one for the shoulder, which is a bit more flimsy. This is a rock solid construct. It's formed through circular and longitudinal bands. The longitudinal bands are often free of really thick ligaments. We can see them here, the pubofemoral ligament, the ischiofemoral ligament, and the iliofemoral ligament. The strongest of which is the iliofemoral ligament, but all three are crucial for stability of the hip. So this is the hip capsule. Now on to blood supply. We'll go through this quite slowly. So A and B delineate the medial and lateral circumflex arteries, of which the predominant blood supply to the head of the femur is the medial circumflex artery. This is a branch of the profunda femoris, which is in turn a branch of your femoral artery. C is a vascular ring formed when these two meet. D are the retinacular branches that are given off from the vascular ring. These travel up towards the head, perforating it, and also giving off the majority of the blood supply to the femoral head. There is also, there are two other sources of blood supply, firstly from the medullary canal, and also from the ligamentum teres, which is delineated as E. The ligamentum teres is less important in adults, but could be quite important in terms of blood supply in children. So if I draw the capsule from the previous slide, everything starts to fall into place. A fracture into the capsule could, it doesn't have to, but it could disrupt the blood supply to the femoral head. If that blood supply is disrupted, then it doesn't matter how well you reduce that fracture, the femoral head is going to die, which is what we call avascular necrosis. Likewise, an extracapsular fracture should not disturb the blood supply. So we're going to talk about intracapsular versus extracapsular. That's our very first classification. And I'm sure you guys are all familiar with that anyway. We're going to start with intracapsular. So we have our intracapsular fractures. The next question we need to ask ourselves is, are they displaced or undisplaced? One of the classification systems that we have for that is called the Garden classification. It's something that you need to be aware of. And again, this follows and often is descriptive of the trabecular patterns that we spoke about before. So you have A and B, which A is an incomplete fracture, B is a complete fracture, undisplaced. C is when the is a complete fracture with the trabecular patterns disturbed, and D is a complete fracture that is completely displaced, where the head basically has no relation to the neck. It's not entirely that useful a classification and can be simplified into simply displaced or undisplaced. So let's draw our lines on this radiograph. So if we start with Shenton's line, we can see that that, to me, looks all right. But if we start drawing our trabecular patterns, we can see a clear disruption in the trabecula with that sclerotic line that just comes through. So we have to be suspicious here that this femoral neck is fractured. However, it is not displaced. So how are we going to treat it? Oh, I beg your pardon. I have to run through that again. So undisplaced intracapsular fragility fractures can be treated with fixation in situ. The most common things that we use are dynamic hip screws or cannulated screws. We are going to talk about dynamic hip screws a bit later on, so we'll focus on cannulated screws. So these are cannulated screws. I'm sure you've seen the x-rays before. They're not done anywhere near as frequently as dynamic hip screws, but you can see a fracture line here. And I'm just going to add in 2 more, and then I'm going to ask you guys a question. So the first fracture line we're going to label as B, and then I've drawn A and C. And my question is, which fracture configuration do you think would be least stable having been treated with cannulated screws?
Let's give another 10 seconds.
Yeah, just realized I can't see the answer.
I'll show in a second.
Okay.
All right, 5, 4, 3, 2, 1. All right, there you go.
Perfect. Good. Good. So basically what you guys have described there is Powell's angle, okay? Which means that the more acute the angle, the greater the shearing forces are on your construct. So you can see the more vertical it is, the more strain it's going to put on those 3 screws. In fact, C is usually recommended not to have been treated with cannulated screws. They would prefer a more stable construct, like a dynamic hip screw. Just to also go over some of the principles of cannulated screws, we use 3, and we want to get threads that go beyond the fracture site. If you have threads that cross the fracture site, then you don't achieve compression. All you're doing is holding the 2 fragments in place. You want a triangle configuration because this has been shown to be the most secure construct. And it doesn't matter if that triangle is upside down. Another tip is that you want maximum spread of your hardware in the neck. How undisplaced does it need to be before you can treat with fixation in situ? There's loads of studies on this. The one I'm going to highlight is by Lawrence et al. And this is a study that looked at 878 intracapsular fractures treated with cannulated screws. What they did is they retrospectively went and analyzed the AP and lateral x-rays and categorized the initial displacement into either undisplaced, partially displaced, or displaced. What they managed to demonstrate was a linear relationship in the complications. The complications being non-union and avascular necrosis. So even in undisplaced fractures, 20% of them that are fixed in situ went on to have complications of either non-union or avascular necrosis. But in partially displaced, that's 30%. And in displaced fractures, 45% of them go on to have non-union or avascular necrosis. And that's quite an unacceptable treatment. Remember, our priority is to give these guys one operation that allows them to weight bear in the immediate post-operative period. So let's go through another x-ray. Let's draw our lines. The Shenton's line looks all right on the right. It does not, on the left, sorry, but it looks significantly disrupted on the right. So this, again, I just highlighted the capsule there to remind us that this is an intracapsular displaced fracture. So how are we going to treat these? We know that the head is at risk of avascular necrosis. In the elderly, the advantages of definitive arthroplasty outweigh any potential benefits of preserving a displaced femoral head. So we treat these guys with arthroplasty. Now, that can be a Hemi or it could be a total arthroplasty. The key points are that whatever prosthesis you use should last. So we're going to replace the femoral head and neck with a femoral seated prosthesis at the minimum. This should be a cemented femoral stem, although there are some risks with this, including hypoxemia from fat embolisms. Uncemented stems have a higher risk of fracture in osteoporotic bone, And also, because they have poor quality cancellous bone in this age group, you may not get your interference fit, which means it may go on to be unstable. You can use a monoblock, which is a single block head, or a bipolar head. The bipolar head is thought, the theory is that it decreases acetabular wear and it decreases the rate of dislocation. What it is a small articulating head, which then articulates with an outer shell. So when do we do total arthroplasty? Well, there is some guidance on this. The NICE guidance states that we should offer a total hip replacement for intracapsular fractures if our patients are able to walk independently out of doors with no more than the use of a stick and are not cognitively impaired and are medically fit for anesthesia and the procedure. However, how many of these people who meet this criteria do you think actually get offered a total hip replacement? Well, the data shows that it's less than a third. Why do you think that is? Well, we know that total hip replacements are longer operations. They're associated with more blood loss, more complications, but better function, and they can have better survivorship. There's a lot of data on this. I'm just highlighting one meta-analysis from 2019, which demonstrated that total hip replacements had a significant risk of dislocations. But in the fittest cohort of patients of these elderly neck of femur fractures, it also had a 12-month lower mortality and revision rate. So I think the jury is basically still out on this. So what I'm going to do is I want you guys to have a look at this X-ray, and I want you to decide your treatment, and I'm going to give you some patient information. You can have a read of it. I'll just read it out. This is a 78-year-old female. She mobilizes independently to the shops and back. She lives in a ground floor flat. She has type 2 diabetes, which is poorly controlled. Also has past medical history of hypertension, AF, and previous breast cancer, although on no active treatment currently. She has an AMTS of 10 out of 10. How would you treat her? The options are a DHS, a Hemi, or a total arthroplasty.
Another 5 seconds.
Okay, so it's quite split, isn't it? 60% would do a Hemi, 35% would do a total hip replacement. And in truth, there is no exact correct answer to things. A lot of the surgeons you work for in your practice will swear by the end of the bed test, because that past medical history there really doesn't tell you enough about the patient. So most people will go and see the patient, and their gut instinct usually tells them. Right? We don't seem to have clear guidelines which distinguish or can account for that yet. So both options are available. So we've got a bit of a classification system now for intracapsular fractures, right? We can decide whether displaced or undisplaced. If they're displaced, are our patients high demand or are they low demand? If so, we can offer them a total or a Hemi, depending on which one they are. For the undisplaced fractures, we can try to fix them in situ, but we know even in the really undisplaced fractures, 20% of them will go on to have complications. The ways in which we fix these are usually with DHSs or cannulated screws. So we're going to move on to extracapsular fragility fractures. The main point of this is that the blood supply to the femoral head should be preserved. So how do we classify extracapsular fractures? There's mainly only two arms that I would use, and it's intertrochanteric or subtrochanteric. But for those of you who want to know, there are classification systems out there. This is the modified evidence classification, but it's very, very descriptive. It does inform you about the different fracture patterns that you C. So if we go from left to right, or 1 to 5, the first one are basicervicals. The second are intertrochanteric. And those two can normally be lumped together because they're quite amenable to fixing with a DHS. You just compress across that fracture site. Both can be prone to rotating when you're reaming. So sometimes you may find yourself needing to put in a second guide wire or a derotation screw before you ream. The third one is self-explanatory. It's multi-fragmentary. But what's important to recognize about this fracture type are that they can often collapse, they can be difficult to reduce, and you need to be aware of whether your lateral wall is intact, because that dictates whether you can use a dynamic hip screw or not. The fourth one are reverse obliques, which only make up less than 2% of all neck of femur fractures, but they're certainly ones that we should all be aware of. And the fifth category, subtrochanteric, we also need to be aware of, because both of those are highly unstable fractures. This I would class as an intertrochanteric. This I would class as a subtrochanteric. So let's talk about, now that we can classify them into broad categories, we can talk about how we go about fixing them. So you're all SHOs, or most of you are SHOs, so you should all know about DHSs, and I'm sure most of you will know about nails. But do you know what a DHS is? Right, so a DHS is comprised of 3 components. It's got a lag screw, which drives into the femoral head. It has a barrel, which is attached to a side plate, which is attached to the lateral wall of the femur. The lag screw articulates with the barrel, and it's usually a square. This means that it can slide at a fixed angle through that barrel, but it should prevent rotation. Bear in mind that for a DHS to work, it needs an intact lateral wall. The other thing to mention, as I'm sure you guys are getting used to this as you are starting to head to theatres and be involved more in these cases, is the triple reamer. This is how we insert our screw and our barrel and our plate. And essentially it creates a path for the 3 different sections. It creates a path for the threads of the screw. It creates a path for the barrel of the plate, and it also creates a path for the barrel plate interface. You guys should all know this, the tip apex distance. It's a famous paper, which has been described multiple times, and I knew it very well as an SHO. It was my main focus, which basically describes that the tip of your screw needs to be near the center of the head on both views. This is the AP and the lateral. The combined distance of both of those should be less than 25 millimeters. Otherwise, there are associated increases in complications. So how does a nail work? Oh, sorry, no, before that, this is a picture of a DHS with a good tip apex distance, but we would need to add the lateral tip apex distance as well. So how does a nail work? Well, for hip fractures, we use cephalo, which means head, medullary nails. So parts of them are similar to a DHS in that it's a fixed angle device, which means that you can use it in sliding compression, but you can also use these as static, which basically just attaches the head on a pole to the shaft. It has some advantages over a DHS, in the main one being it has a shorter lever arm. And what do we mean by lever arm? Well, if you tuck your elbow into your chest and then hold out your palm, if someone was to give you a heavy weight, you'd be able to have greater control of that than if you were to fully extend your arm and they were to give you the same weight. So it's a more stable construct. It can be done percutaneously. You can have long or short nails, but it does have some technical difficulties, and that is thought to be more technically difficult than performing a DHS. Your entry point is absolutely everything, and it can be associated with periprosthetic fractures. The other thing to note is also it's a lot more expensive than performing a dynamic hip screw. This is just a slide on your entry point. Now, it's important to note that not all nails have the same entry point, but roughly you can see the line that delineates the correct entry point. If you put your nail, especially in this case, lateral to the entry point, you can see that it actually mal-reduces the fracture and leaves it in varus. And one of the big take-home points from today is that varus is always bad. So, a couple of summaries for extracapsular fractures. We need to consider the stability of the fracture when choosing our method of fixation. As mentioned, basicervicals or even intertrochanterics, you should consider a derotation screw before reaming to stop your head from spinning. Reverse obliques and subtrochanteric fractures are not amenable to DHSs. Also, if you're in any doubt about the stability of your construct, you should go for a long intramedullary nail. So this is an example of a reverse oblique fracture. Now, we should know that these are not amenable to DHSs. We can't use DHSs for this. However, we decided to, and you can see, you can just faintly make out the fracture line just beneath the screw there in the barrel, but you can see that the fracture line is in the same plane as that. So therefore, when this fracture slides, which the screw will allow it to do, this construct is going to fail. And unfortunately, of course it did. So what happens in that is you get medialization of the shaft whilst the proximal fragment slides laterally. So we've now also got a classification system for extracapsular fractures. The main one is to decide whether they're intertrochanteric or subtrochanteric, but you can further divide those intertrochanteric ones into simple, multifragmentary, or reverse obliques. For your simple ones, DHS plus or minus an anti-rotation screw is more than acceptable. For your multifragmentary ones, you want to be considering whether it's stable. The Americans used to describe it as posteromedial stability. Sometimes a DHS will be appropriate, but sometimes you may want to perform an intramedullary nail. And reverse obliques, you should be performing an intramedullary nail, as the same is with subtrochanterics. So I know that's a lot of information, but we've kind of worked out how to classify both intracapsular and extracapsular fractures, and we've gone over some of the treatment methods and described how those work and the biomechanics around them. Just quickly to touch on the young adult hip, this is an entire topic on its own, but I just want to stress on how it's different from fragility fractures. So fragility fractures are falls from standing height. The young adult hip is usually high energy trauma. We said that it's not worth trying to preserve the femoral head in the elderly. However, it is worth trying to preserve the femoral head in the young adult hip. This is because you're otherwise committing them to a lifetime of arthroplasty. So the important parts for it are early anatomical reduction, and that can be done closed or open. Other thing to note is that 10% of femoral shaft fractures will also have a femoral neck fracture. That's a very brief overview, and it's obviously a much bigger topic than that. But that's why it's different from fragility fractures, because there's a lot of energy involved, and you do want to save that head. Okay, so I think in conclusion, we've gone over guidelines, the tariff, things that you need to be aware of. We've touched on the anatomy and the blood supply, how we classify things, and how in deciding treatment, both the patient's physiology and biomechanics are important, because we can then use different constructs. And again, to reiterate, you want to preserve that young adult femoral head. These are just some of my references.
Awesome, Anthony. Thank you so much. Love the animations. You show me how you do that next time. We've got no questions for you, so thanks. Just remember we got a brief afterwards. Now we're going to move on to surgical approaches to hip fractures by Mr. Alazzawi.
Thank you very much, Kana, for the invite. My name is Sulaiman Alazzawi. I'm a consultant orthopedic surgeon based at St. George's Hospital. So we're going to talk about the surgical approaches, and we focus mainly on the common approaches. We try to keep it simple and just to take the key steps on each approach. Okay, so when we talk about any approach in general, there's a Hemi approach for the forearm or the shoulder, or the thigh or the leg. It's very important to take three parts of that approach. Know the indication of the approach, what's this approach used for, the advantage of using it as opposite to other approaches for the same purpose, and the limitation of that approach. And for each approach, we need to know the structure at risk that we can injure during that surgery. So one way of having that structure for you, whether you are in the interview or in the exam, if someone asks you, tell me about the approach of the lateral approach of the hip joint, start by mentioning three fundamental things, which is the patient position, the landmarks, which is going to be the skin landmarks for you, and what structure at risk. And then after that, you start talking through the approach. And once you mention this, everyone knows, whether you are in an interview or exam purposes, that actually you know the approach very well. The hip joint is one side of the body where you can actually approach it 360. You can have approach it from the front, from the back, or from either side. We're going to start by talking about the posterior approach because it's one of the common approaches used for the hip joint. The posterior approach, also known as Moore approach or Southern approach, or the modification is Cocker-Langenbach. Cocker-Langenbach is more extensile part of that posterior approach. It's commonly used in the trauma setting where you need to fix the posterior column or you need to access the acetabulum for more fixation. But the common type of approach you see in the operating room is the standard posterior approach where we use commonly for hip replacement, as well as use whether in the primary setting or in the revision setting. We use as well in the fixation of the posterior posterior acetabular fractures. Is uncommonly used in hemiarthroplasty because of the dislocation rate. The advantage of the posterior approach is easy, is reproducible. As a trainee, you can see it once or twice, and then you can actually, I can start doing the posterior approach. It gives you excellent visualization for the femur and for the acetabulum, so it's very useful for revision setting. If you want to extend, if you want to do total femur, you can extend the whole approach to do total femur replacement. You can do extended trochanteric osteotomy. So the visualization, the exposure is great, and it doesn't interfere with the abductors, which is key things for rehabilitation after the operation. The limitation of this approach is the injury to the sciatic nerve because you're operating very close to the sciatic nerve, and there is a historical perceived of increased dislocation rate in hip replacement if you use the posterior approach, because the old data shown when the surgeon didn't used to prepare the posterior capsule. Now we are more aware of the orientation of the implant, so we align our implant with a suitable antiversion, minimize the risk of dislocation. In high-risk patient, we have more options of implant, like using elevated rim liners or using dual mobility, as well as we repair the posterior capsule, the short external rotator, and that will add more stability to the joints. But nevertheless, it is a slightly higher dislocation rate in comparing to the other approaches. We will talk about it later on. The position of the patient will be supine position, and it's very important in operating room. As trainee, you're going to position the patient with whoever supervising you, whether a senior registrar or consulted. Simple things, very important. You use a lot of side support to position the patient. The key on the side support have to be well padded, otherwise after a long operation the patient will end up with a pressure sore from that. It will be a red skin to start with, then you see them after 3-5 days start blistering, and then you end up with big necrotic skin. The other things, as you can see in the photograph of the image below, you should be able to flex the hip 90 degrees. You should be able to mobilize the hip during the operation, because if you are doing a hip replacement or hemiarthroplasty, you want to check that the joint is stable during the operation. So these side supports should not stopping you from moving the joint around. Also, it's important when you apply all the side support to ensure that they are not going to be the way of your incision, because remember, on the top of that, you're going to prep the skin, you're going to put drapes, and you should have still a good skin access to the area you want to operate. So they should not be obstruct your surgical field. The skin incision or landmark based on the greater trochanter. You try to feel the greater trochanter. You feel where's the interior border of the shaft, femoral shaft, where's the posterior border. In obese patient, you may elect to use your other hand to abduct the femur to try to feel where's the greater trochanter, and you can use a marking skin marker and mark where are the shaft, where's the interior border, where's the posterior border, where's the tip of the greater trochanter, and you curve around the tip of the GT. Usually, if you divide the width of the femur 2/3 to 1/3, you are mostly in the junction between the 2/3 and 1/3. So you are slightly more posterior on that skin incision than being anterior. You incise the skin, and the next things you have a fat, and then you have the fascia lata. Once you incise the fascia lata, you approach here with a short external rotator, and you identify this muscle, which is the piriformis muscle. You go into the plane between the piriformis and between the gluteus minimus, and you stay on that plane, and then you incise the piriformis and the rest of the short external rotator. You don't have to excise the quadratus femoris routinely, but you can do if you want to bigger exposure. And once you excise this muscle, you reflect them, and most surgeons, they put stay stitch on that, and then you have the capsule. You can either incise the capsule as a separate layer, or many surgeons, if you go to the previous slide, they excise the whole layer as one. The capsule with a short external rotator, you take everything together as one layer, and then you have the hip joint exposed right from the back. Now, when we talked about the sciatic nerve, is not miles away, and one of the earliest steps before you start detaching any muscle, once you open the fascia lata, you try to allocate where is the sciatic nerve. There are a lot of anatomical variation, and the sciatic nerve could be in certain cases much more closer to the edge of the short external rotator, or divided quite a higher level, more than you expect. So it's very important you first will identify the sciatic nerve, because it's not far away. Sciatic nerve injury can happen for many things. It can be direct injury, whether this is with a diathermy or the knife is unlikely, but the most common cause of sciatic nerve injury is retraction, whether this is from your retractors. So very important when you put sharp hormone or you put anything, you just think where is this in relation to the nerve, because the most common injury for the sciatic nerve during the operation is from the retractors. You put it without noticing where is your sciatic nerve. Other structure at risk is the branches from the inferior gluteal arteries. So these are branches is very useful to identify them early. Use a diathermy to cauterize these vessels. If you leave them or you injure them, all these tiny vessels, they tend to retract between the muscle fibers, causing persistent oozing. Is very difficult later on to try to find them to cauterize them. So it's much useful if you identify it is in the way where you need to approach. It's better to diathermy the vessel early. Okay, so in summary, for the posterior approach is a good exposure, but you always have to think where's the sciatic nerve. That is the key of this approach. You have to protect the sciatic nerve throughout the actual operation. We move on to the next approach is the direct lateral approach. This is a very common approach. You might have seen it many times in fracture neck of femur for the hemi arthroplasty. The direct lateral approach, there are many modifications of this approach. There's the original Hardinge approach, which is done with a supine position with trochanteric osteotomy. There's the McFarland modification, where you actually detach the muscle directly from the bone with small flick of bone coming from it. But what you see most commonly nowadays, what most surgeons use, is a modified version of all these different descriptions, modified Hardinge approach. And that's the reason you see always in the operation note they write modified Hardinge approach. What they mean actually is transgluteal approach, commonly used for hip hemiarthroplasty. Some surgeons still use it for total hip replacement. It's less risk of dislocation when we compare to the first approach we described, the posterior. most people familiar with it because as a junior trainee, you start involved in operation. You start the common operation you're going to be involved as SHO, as junior registrars, is ankle fixation, distal radius, and the fracture neck of femur. And this is the approach used commonly for fracture neck of femur for hip hemiarthroplasty. So all of us, you find you actually very familiar with the approach. You've seen it many times before. And the transgluteal approach, the advantage of it, or the modification that we use nowadays, you don't need to do any osteotomy. The limitation or the problem of this approach, you are cutting through the abductors. So if you don't repair the abductors well, or you injure the superior gluteal nerve, you end up with a Trendelenburg gait for the patient. And this approach, it doesn't give you excellent exposure comparing to the posterior approach. So the setting for the revision setting, many surgeons may elect to go back to the posterior approach because it will give you a better exposure if you want to have exposed large part of the proximal femur. Position again supine, and again same principle. These should be gel pad, no pressure area. We're able to move the hip to test for stability, and they should be away from your surgical field. Landmark, again, the greater trochanter, but you don't need to go as posterior as you had earlier in the posterior approach in the skin incision. You can either make a straight incision, or you can even curve it a little bit posteriorly to give you better exposure for the acetabulum if you're planning to do total hip replacement, but you don't need to go with your skin incision very posterior. You make your skin incision, and then you have the abductors exposed as this. Now, before we go further with the abductors, just to remind ourselves, where is the superior gluteal nerve? Because that's the key of this approach to protect the abductor function. We're looking here on the image on the left side from the posterior part of the hip, and you can see the branches of the superior gluteal nerve coming is around 3 to 5 centimeters above the level of the tip of GT. And this is very important as how we're going to cut the muscle and where we're going to which area we need to avoid. So if we're looking at the hip joint and we look at this circle as the tip of the greater trochanter, you don't want to go above that. And that's the reason the hip is based here. We make a cut parallel to the muscle fiber here, and usually try to make another cut here through this white material, which is give you a good material to prepare the tendon toward the end of the operation. You would not cut through the muscle fibers because they will be shredded. They will not be able to repair at the end of the operation. And you can see the gluteus medius tendon is quite large. You don't need to get all the muscle out. You need to take probably 1/3 or maximum half of it and leave the large part of the proximal part intact, which will help you to preserve the function and as well make you safe. You are staying away from the territory of the superior gluteal nerve. After you cut the muscle, you reflect it, and then you do the inverted T capsulotomy. In hip hemiarthroplasty in particular, most surgeons will preserve the capsule so you can repair it at the end. Maybe in the revision setting or in hip replacement, some surgeons elect to excise the capsule completely and rely on the implant position. But for hemiarthroplasty, most surgeons will preserve the capsule so you'll be able to repair it toward the end of the procedure. After that, you have the neck of femur in front of you, and if you are doing primary hip replacement, you will do neck osteotomy after you dislocate the hip joint, or if it's a fracture neck of femur, then you can retrieve the femoral head. So structure at risk on this approach. In the posterior approach, we have the sciatic nerve. Here, on the direct lateral approach, we have the superior gluteal nerve, and this is the key of this approach. Always remember that. Other structure like femoral nerve or artery, they should be far away. You may get some branches from other vessels, but these are not common. If it is in your way or injure them, obviously you have to deal with it with ligated, that's small vessels. So the key of this approach, remember, is all about protecting the abductors, because you're going to cut part of the abductors. You have to preserve the nerve which supply the muscle, otherwise the muscle will be atrophied and there's no point, the patient will end in limp for the rest of their life. And you have to have really robust repair for the abductors at the end of the operation to be so the muscle will heal, and in a few months time after the surgery, muscle power will regain, and then the patient will have a normal gait. The other approach on the lateral is the intralateral approach. It's not commonly performed nowadays. it utilizes the interval between tensor fascia lata and gluteus medius. This approach can be done with a patient supine or lateral position, and you can access the hip joint in two ways. Either you do trochanteric osteotomy, as you demonstrated here in this line. You cut part of the tip of the GT with the muscle attached to it and retrieve that part, and that will give you access to the joint capsule. Or you cut part of, reflect part of the interior part of gluteus medius and minimus, more or less similar to what we did on the transgluteal approach. This approach, known as Watson-John, is not commonly used nowadays, at least here in the UK. In the practice, we don't commonly use this approach. Interior approach. An interior approach commonly done and is important approach to know. We use it mainly for the irrigation and debridement of septic arthritis of the native hip joint. So this is an important approach to know for emergency setting, because if you have a patient, whether a pediatric patient or an adult with infected native hip, infected of septic arthritis, need urgent washout, this is the approach of choice, because you are not cutting any muscles here. But recently has been popular as well, using it for total hip replacement, whether you use a traction table with it or off the traction table. And you can use it, it can be used in the pediatric setting for the reduction of dislocated hip joint. So the anterior approach, the original description is Smith-Peterson approach, is a plane between the sartorius muscle and the tensor fascia lata. So it's internervous plane, because you are operating between two muscles supplied between two different nerves. And then we go deeper between gluteus medius and rectus femoris. Now, if we go back to the, let's go forward. So on the skin incision, patient will be supine on that approach. Your landmark is the anterior superior iliac spine, and you draw a line almost aiming toward the lateral side of the patella. So actually, it's much more lateral than you think your skin incision. And this is tensor fascia lata, sartorius here. I draw you at the approach here, and I draw your attention to the yellow structure here. We'll talk about it shortly. This is the first layer, and after that you go to deeper layer. If you isolate this muscle, you go between gluteus medius and between the rectus femoris, and you're going on that plane again. So in theory, you are actually just separating the muscle far in the same longitudinal axis of the muscle fibers. So you are yet haven't cut any muscle, and that's what makes this approach very desirable, because you are protecting all the muscles. And once you're there, sorry, this is a repeat of the same slide. Once you're there, you approach the hip joint. Now, the structure at risk is the lateral femoral cutaneous nerve, the yellow structure. We talked about it earlier. It's quite early in your approach. You approach the lateral cutaneous nerve here, and it is commonly injured, and depends on the paper you read and the literature you report. Some people reported 50, 60, and others reported 5 or 10%, but it definitely, it does exist. You need to identify it early. You will see it is a big structure, it's not small structure, and you have to try to protect it. Otherwise, patient will end up with a large area of skin numbness around the lateral aspect of their thigh, or more importantly, sometimes they get neuroma and causing pain for them. So we will try to protect that approach. The femoral nerve should be far away. You need to be aware where it is, but it should be far away from that. And there will be a lot of vessels in that area that need to be ligated or cauterized with diathermy during the approach. So the key of this approach, protect the lateral femoral cutaneous nerve, because that's the most commonly injured structure during this approach. And the exposure can be limited. So it's useful to do washout of a hip, useful to do hip replacement, but it's not an approach you want to decide to do a revision surgery through that anterior approach. The medial approach, that's the last approach we're going to talk about today, is really uncommon approach, but you need to be aware there is a medial approach to the hip joint, and it's commonly used in pediatric settings for congenital, for reduction of congenital dislocation of hip joint. Patient put in this position where you tense the adductors muscle here and try to feel where are the adductors, and your line will, the incision line will be among the excess of the adductor muscle here, adductors longus, and you go around the muscle fibers of the muscle, starting from where high up, where you feel where's the pubic tubercle, where the muscle starting from. Try to palpate it against a lot of against the contraction of the muscle, which we give you. You're able to palpate the adductor longus. Once you separate it, you go between the gracilis muscle here, as you can see, and adductor longus, as you can see on this dotted line. And then you go to deeper layer where you go between adductor brevis and adductor magnus. This, as I say, is not a common approach to perform. Most people, if the patient have a lot of adductor tightness, they do adductor tenotomy rather than do the full approach, but is an approach need to be aware. It's commonly used in pediatric, it's not, if it's going to be used, it will be used mainly in pediatric setting, but overall is not uncommon approach, definitely in adult patients. So these are the most common approaches for the hip joint. You will, as I discussed, there's a lot of modification for each approach of them through the years. The most common two approach, you need to be aware of the posterior approach for the hip replacement and the transgluteal direct lateral approach for hip hemiarthroplasty. The anterior approach is a good approach and handy approach to have for emergency setting for washout of native hip joint, and occasionally for hip replacement if the surgeon elected to use that approach. So just to summarize, for each approach, we need to know the advantage, the indication, and the structure at risk. And as a good tip to learn, if you want to describe any approach, you need to start by describing the patient position, your landmarks, and the structure at risk. Thank you very much.
Awesome. Thank you so much. Thank you, Anthony and Mr. Alazzawi, for your great talks. I would also like to say a great big thanks to our sponsors, Arthrex and Leader, for making this possible and absolutely free for you guys to attend. If you guys could fill out our feedback form, it'd be much appreciated. And just a quick reminder that our next talk will be next Wednesday, which will be on injuries to knees. Oh, sorry, we just got a question coming through from Zaid. Which approach would you use for open reduction for a neck of femur fracture?
That's a very quick question. It depends on the implant you're going to use. So most of the time you find it will be many approach with a lot of small incision, and you put a lot of either shunt spin or you put a lot of percutaneous tool, try to reduce the hip rather than doing a fully open reduction. So if you, let's say, if you're planning to fix it with, let's say, is intracapsular in young adult patients, and you try to preserve the head, you will use DHS, and you will have multiple small step incision to try to joystick the femoral head to the reduction rather than formally open the whole hip open, because you try to preserve as much blood supply as you can.
Awesome. There's no other questions. Mr. Alazzawi and Anthony, if you just wait till we'll go to breakout rooms.